Welcome to Music and Medicine on Monday, a collaboration between the College of Medicine and the School of Music here at the University of Iowa. This podcast is designed to help musicians play and to stay healthy. Today's session is focused on the palate and velopharyngeal weakness, and more specifically, on playing the trombone after cleft palate repair. Velopharyngeal incompetence and eustachian tube function will be discussed. This video is supplemented with more written detail on the free medical website called the Iowa Protocols that you can access by the QR code or the website address below. We're coming to you from the recital hall in the Voxman building in the School of Music at the University of Iowa. My name is Harry Hoffman. I'm a physician at the University of Iowa, and our featured performer today is Killian Ritland, a student in the School of Music, focused on trombone, planning a career as a professional trombone player. Our guests today are John Kennedy, Professor Emeritus, University of Iowa Departments of Otolaryngology and Plastic Surgery, and former bass player, card-carrying member of the Iowa Musicians Union in the past. Jonathan Allen is the Professor of Trombone here at the University of Iowa. Killian, can you tell us a little bit about your background that led you to this point, establishing a career centered around music in general and more specifically the trombone?
Absolutely, and was very lucky to be born to a fairly musical family. Father played the tenor saxophone when he went to Iowa here many years ago. Played in the jazz bands, did marching band, and just kind of was around that my whole life growing up. And I knew at some point I was going to play an instrument, and I convinced myself, when you get to that point in 5th grade, it's going to be saxophone. And I was like, and I played that trombone, and that slide was just too fun. And I just haven't left it ever since. And originally they told me there might be some issues with the cleft palate and lip and palate and the playing, but I just kept trucking, and I've gotten here, went through high school, and decided about during COVID, I found myself, I was like, I actually enjoy practicing and playing all the time. And I reached out to Dr. Allen and realized that I wanted to do this full time. So, I'm very, very lucky to be born in such a perfect area of medicine to fix me and music to heal the soul. So I'm pretty lucky in that regard.
And with that, we will proceed with the performance. Killian, that was great. Jonathan, do you want to comment on Killian's performance?
Sure, absolutely. Beautiful playing. When the Saints Goes Marching In is one of the most classic, kind of timeless things in jazz, in the history of jazz, the evolution of jazz. So it's great to show it. One of the things I appreciated about that was that you used the plunger mute, and it kind of, I think really lead into our discussion.
Yeah.
Because the trombone should be, it's a high airflow instrument. It's a large instrument, has a large mouthpiece and bell, but should be a really low pressure instrument. For somebody that's had cleft palate repair, keeping low pressure is really essential because, as Dr. Kennedy will talk about, just the reconstruction of the soft palate. But adding that plunger really complicates things by adding a lot of back pressure.
Mm-hmm. Great. And John, do you want to describe what a cleft palate is and how it differs from the lip and its management, perhaps?
Sure. And thanks for providing this model, Harry. This is a cross section, so if you slice the head right down the middle, this is what, and looked off to the side, this is what you would see. So these are the teeth, the nose, the top of your mouth going back to the soft palate and the uvula, the little punching bag thing in the back that everybody always talks about, your tongue, and then on down into your food tube or esophagus or your windpipe down to your lungs. Cleft palate has a split, usually at or near the midline, so there's a gap between the mouth and the nose. And the palate serves numerous functions, but in this context and in just normal everyday day-to-day life context, you need to be able to seal off your nose from your mouth. And you need to do that when you're drinking liquids, or the liquids will come back out your nose. You need to do it when you're eating food, or some of the food particles will come back out your nose. And you need to do it when you're speaking as well. And there are certain sounds in all languages that are specifically designed to come out just your mouth. There are other sounds that are designed to come out your nose, like 99 is a nasal sound. If you put your hand up, you'll feel the air come out with 99. Coca-Cola is a specific oral sound, 100%. So if you don't have your cleft palate fixed, or if it's not completely closing, a sound like Coca-Cola becomes Coca-Cola, where the air actually leaks out your nose. And obvious implications for playing an instrument. If you know you're having trouble just with the breath support with speech, this is going to be incredibly difficult, because the air will just leak out your nose and you can't build up the necessary pressure. There's a number of ways to do this. Much like the lip, there is a mucosal overlay of the palate. The middle layer is muscle, and there are muscles that run in different directions. So part of the palate movement is just up and back, but part of it is also like a ring of muscle that constricts down in that area.
You're talking of the soft palate, not the hard palate.
Soft palate.
The non-bony area.
Yeah, the front part of the palate, good point, front part of the palate is bony, but kind of the action part of the palate is in the back where the muscle and the so-called soft palate. This goes up and the back wall comes forward, so it creates a tighter seal at that point. And the ideal outcome for a cleft palate repair is to have be able to make that seal not only with speech but with any other activity that you want to accomplish. But you don't want it to be overclosed where it sounds like you have a cold or your nose is stuffy and air can't escape from the nose when it's supposed to. So there's kind of a sweet spot of palate repair and ancillary operations for that palate that puts you where your voice sounds normal, you can eat and drink without difficulty, and if you want to, you can play a brass instrument too.
And what age do you do the palate repair?
So again, it depends a little bit on the presentation, the health of the kid, and the size of the defect. But usually that's all wrapped up by 18 months or within the first 2 years of life.
And then there's some ancillary procedures that I believe Killian had to try to close off that port when it doesn't close off on its own.
Right, and sometimes particularly with bilateral cleft situations, you're just maybe a little short of tissue even after you've got everything to heal up correctly. And so you can do a procedure called a pharyngeal flap, where you bring tissue from the back wall of the throat. So if you went and you took a pencil between your teeth and just went back until you hit the back wall of the throat, you leave that attached at the top, and you can swing that up and add tissue in to the soft palate, kind of in the midline, and again, just make it that much easier to close off when you need to from leaking out the nose.
And what age do you do that?
So typically you do that when the patients have demonstrated they're having difficulty with those speech sounds. And that's back to, what we talked about earlier, where I'm not a speech pathologist, but, fortunately there were great ones when I worked over at university hospitals. And so they have a battery of tests. They put the patients through, and we discuss it. And if it looks like that procedure would help their speech, then usually around 5, 6, about the time school starts, to let the kids participate in school without being teased about their speech. And also, there's a reason school starts at 5, because kids can cooperate a little bit more long term. They can participate in the speech therapy sessions in a meaningful way. So usually those operations are done around 5 or 6. And there's other procedures that you can do too that will address that same thing. But Killian had a pharyngeal flap.
So it's a long-term program. I understand you have a picture of Killian shortly after his pharyngeal flap. Killian, when did you start playing the trombone?
I started playing trombone when I was in 5th grade, so that's a long time to think about.
Do you recognize that picture? How old were you then?
I do. I believe would have been about 5th grade. That would have been, I think, one of my first concerts, if I'm not mistaken. And I never thought that I'd be a trombone player. I always thought I'd be a saxophone player like my dad. But when you get to the band room, so I think it's if you've ever seen some movies, I think the instrument picks you. I don't think you really get to choose what you like. It just kind of happens, and I've been loving it ever since. But yeah, it was interesting. We've kind of discussed the back pressure and all the different issues. And one of my favorite questions that I get, specifically about having cleft lip and palate, specifically palate as we're talking about, is do you wish you didn't have it? Don't you wish what do you think your life would be like as a musician without it? And my answer is always this, it's 2 things. The first one is, I don't know any differently, so it's not even worth thinking about. And secondly, there's no guarantee that I would have been a better musician without it. There's no way of knowing that. So being able to say that in 5th grade I was able to, that was 2 years after basically one of my last big operations, and be able to do that. That was a pretty big deal for me. So. Yeah,
the term that we use is velopharyngeal incompetence for nasal escape of air. And Jonathan, I understand you have another term for it.
In brass teaching and playing circles, we often call it soft palate incontinence, probably because we can't pronounce the other word because we're just trombone players. But the way it would come across for a trombone player or a brass player is while they're playing, you would hear a sound. You hear sound escaping into the nasal cavity. And that's a really pronounced version of it. Sometimes there may not be the vibration of that, but that's one of the most common ways that it kind of manifests while playing the trombone. And it's usually on an attack. So the tongue is kind of closing the mouth, and that increases intraoral pressure. Or if they're going into the high range, which requires increased airspeed.
And I understand if you want to show your 2 instruments, you've made some adaptations for Killian's to enable him to not require such high back pressure. Is that right?
Yeah. If we could imagine in a perfect world, blowing from our lungs to the end of the bell through all of this tubing as one uninterrupted thing, it would be a fairly low pressure thing. But everything we introduce can increase or lower air pressure. The mouthpiece to inside the slide, it's about 10 inches long. It's called the lead pipe, and that takes the bigger, it focuses the airstream into the slide. The way that the bell is constructed, and then the valve. And some of these things, we don't have an infinite budget. We can't go get a custom trombone made that would, remove all these problems. But we did some research and found that they try to get the most open instrument with the largest mouthpiece. So what Killian has, if you were to see it, most people would think that this is a small bore jazz trombone, but it's actually a large bore orchestra instrument. For the trombone nerds, it's an Elkhart 8H, which is very desirable. The post-World War II brass alloys are,
What's the age of your instrument?
The serial number on this leads me to believe it was 1965. Wow. So it's very. I like old instruments. As Dr. Allen was talking about, the alloys are better, but this is maybe one of the most open and less, pressure with back pressure. It's one of the least It's one of the instruments I've had the least issues.
Can you highlight the difference in the valving? It does look like it's a lot simpler than one that Killian has.
So the thing that we could control was the mouthpiece. So we got the biggest mouthpiece it's not the biggest mouthpiece for trombone, but it's one of the larger mouthpieces. And then a typical orchestral or classical trombone will have this F valve. It puts it in a different key temporarily. And that has, even the most open valves, has a right angle. So obviously Killian doesn't have that. So he doesn't have that complication and then the extra weight, which changes the physics of the instrument as well.
Yeah,
Why don't you discuss the plunger and how you can still use that despite, or because of the surgeries that John did?
Yeah, what's interesting is we're talking about how important it is to make it as open as possible. Of course, those who know me in my own personal life know that for some reason I like making as many challenges as possible. So I've been, for whatever reason, attracted to the sound of a plunger on brass instruments since I was really beginning trombone. And what's interesting is, I mean, it's quite literally, we're talking about eliminating back pressure in a valve section or whatever, and then I'm talking that and then single-handedly, as we just saw, putting about the most back pressure you can put on an instrument. So it's, it gives it that nice tone that you might hear from Charlie Brown or something, of the parents, wah, 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 wah.
Can you give us a little Charlie Brown?
Yeah, I mean,
Why don't you demonstrate open and then fully closed and then the Charlie Brown?
So, for example, open, this would be what we sound like on just a tuning B flat for trombones, but versus, we start to close it. So you have to push against it quite hard, and it changes the intonation of the trombone as well. So there's a lot of factors to deal with on that front, but it's I've been attracted to that for quite some time, but that back pressure does cause some discomfort if I use it too long.
That's terrific. Well, I understand we have a couple of guests that we'd like to bring up on the stage. Killian's parents, Mo and Joe. Do you want to come on up here to the stage? Problem with the palate, it often is attached to the eustachian tube.
Right.
And often there's problems with the ears related to the eustachian tube. You want to describe that?
Those same muscles we talked about, also open and close the tube that helps air get in behind your eardrum into the middle ear. It's called your eustachian tube, and it runs from the space behind your eardrum down into the throat area. And there are specific muscles in the soft palate that when you swallow, open and close that valve on the lower end of the eustachian tube. And that's when you have your ears pop, that's the sensation of the pressure equalizing between the back of your mouth and the space behind your eardrum. And so that's an important function, because if that doesn't happen, then you develop a vacuum behind your eardrum, and the eardrum will be sucked back in and unable to clean itself, and you can get into a chronic infection problem with that. So the current most usual treatment for that is to put a little plastic ventilating tube through the eardrum that sort of sidesteps the eustachian tube function and just allows the air pressure to equilibrate across the eardrum through that tube that you've put in.
And my understanding is that, Killian, you had a couple of sets of tubes, but maybe due to John's expertise and technique that your hearing is going well, except for when the instruments are blaring
That
in
is
your...
very true. I've chosen one of the loudest sections, and to most often sit in front of percussion, which is just as loud. So, but yes, very, gratefully I can say that my hearing is quite good.
Can I make a plea for ear protection to use?
Dr. Allen would not be happy with me. We spoke about it as a trombone studio many times, and I've tried to make myself do it when I can, but I'm quite poor about it, unfortunately. But
so, Mo and Joe, do you have some insights or some questions that you'd like to share?
Questions? Well, since we're talking eustachian tubes, I have a question, because I haven't, had a chance to talk to you in a while. He does, it seems to me, in my completely non-medical, world, that when he is in a position where he's playing hard and playing a lot, so kind of like you talked about, Dr. Allen, in terms of the lip, the lip, he also tends to get pain along here and frequently a swollen tonsil on the same side, which causes him quite a bit of pain and I will say it's debilitating only in that then he can't play his horn for longer than he'd like, and he needs a round of antibiotics and has to convince people of what's going on, and that's constantly frustrating. And I don't know if there is a recommendation for someone with cleft lip and palate who's gone through the surgeries. Is it good to have tonsils out? Is it bad to have tonsils out? Is there any benefit to him at this age as a brass player having ear tubes?
Yeah, I think those are all great questions. I think the way that you would work through that is to start with an audiogram that looks at what the pressure behind his eardrum is, and maybe do that a couple of times. We've had experience in the Oto Clinic over the years of adjusting things on musicians under local while they're actually playing. And, I could conceive of a scenario where you could use, it's called a tympanometry bridge. That's the instrument that measures the pressure on either side of the eardrum. You could maybe put that on before and after he plays hard, or maybe during. I mean, that's probably not a thing that's done in a standard fashion. But I think with kids that were born with clefts, the points I've been trying to make is that it's really an individual course, and so it's not one size fits all, and sometimes you need to get a little bit creative in both diagnostics and therapeutics as you go forward. And the good news is, there are any number of treatments that exist now today that didn't exist when we were residents or young men on staff. And so there are devices that you can put in that open up the eustachian tube via a balloon. There are different types of tubes. With the tonsils, you can do a total or a partial tonsillectomy. There's just a lot of choices to make. And I think, the best approach to anything like that, because it's hard to mess with success too. You don't want to get into the opposite of good is better sometimes. And I think, a thoughtful kind of considered approach with appropriate diagnostics, a physical exam, maybe doing some one-off things because of the uniqueness of Killian and his situation. I think it's not unreasonable to revisit some of that, and it has been a while since that probably happened.
So the velopharyngeal insufficiency, the soft palate incontinence, can occur in people that have had tonsillectomies, and so that's some reason to be a little slow in taking out that tissue that can separate the nose to some extent from the mouth. John is very innovative. You can treat velopharyngeal insufficiency in a variety of ways. He had a brass player who was having some nasal escape of air. And John, why don't you tell what you did?
Yeah, over the years I had several patients that presented with velopharyngeal incompetence without an overt or apparent cleft. And again, in the spectrum of clefting, you can have what's called a submucous cleft, where the muscles just don't quite come together. But when you look in the mouth, there's no hole. So that just the muscles aren't formed in a way that maximizes their efficiency. And I've had some double reed instrument players that came in, and the people that come in for things like that are generally higher level players because they've got a big investment in time and their career in their instrument, and then something comes up like that. And there can also be, in the weakness spectrum, there can be neuromuscular weaknesses, myasthenias and other things like that can happen as you get older as well. I took, on a couple of patients, autologous fat, so like fat from themselves via a small liposuction procedure, and then injected it in the back wall of the palate, where that back wall of the throat where the palate normally comes up to meet them. And we did that in the clinic with an endoscope in their nose, and then had them play and kind of tuned that up until they got a solid closure. Because before, the soft palate would just herniate, it would just herniate up and vibrate. And I mean, it sounded like somebody was passing gas in the room, and it was just, the musicians were shattered because it sounded really, really awful compared to the beautiful etude that they were playing. But I think the larger point is there's just a number of approaches that you can do if you're thoughtful and creative, and there are very, very few challenges, as he well demonstrates, that can't be overcome, with persistence and just trying to address it.
So the concept of tonsillectomy, we're counseled from day one as otolaryngology residents to feel the back of the palate, see if it's not quite intact. Sometimes you look back there in that little punching bag that hangs down. Sometimes you see two of them. The word for that is a bifid uvula, and that's on the spectrum of normal to a full cleft palate. And those are hallmarks that make you a little reluctant to do a tonsillectomy. So Joe, you're a sax player.
Yeah.
Can you talk about your influence on Killian?
Oh, well, he probably knows my influence better than I do, but I can say I don't play at his level. I didn't major in music, but I have played my whole life and I care about it greatly. And seeing the four of you and all of your mastery and seeing how you all have kind of played together for him to get where he is, you've beautifully bookended his first 21 years of his life. And what I was going to try to get to is I do play and I care a lot about music. And although I'm not a doctor, I'm in the hospital a lot and I hear doctors talk about good clinical judgment. And it's so obvious, even more so now, hearing you talk about the nuances of how you make some of these decisions. And between the way you did stuff at the beginning and then Dr. Allen now with the way you've coached him through what he's done despite being advised not to, is it's such a gift. We're so thankful for what you've been able to do.
Yeah, I would just like to say, just in this conversation and having listened to all the things you had to say, there's so much innovation that has happened here. I didn't know, Dr. Allen, that people told you not even to try. And it's really hard for me to not get upset when I hear that.
They were wrong.
That's absolutely heartbreaking to me.
Yeah.
As a parent, to hear that the people suggested, don't bother, don't waste your time on this kid. And the fact that you were like, well, I'm going to try. You didn't make any guarantees. You didn't, we didn't even know this, right? At least I didn't.
I didn't until you told me yesterday. But
so bully for you for taking on that challenge, and Dr. Kennedy I can't think of all the countless children you have helped. And I believe from what you said, is this the first brass player you're aware of?
It is.
One of your surgical patients?
Yeah, and certainly, even brass aside, this is the most accomplished, professional level musician to come out of the Iowa Cleft Clinic in my tenure there.
Well, terrific. Well, thank you, Joe and Mo, John.
Thank
Killian,
you. Thank all of you.
Jonathan.
thank you all.
Additional detail regarding this and other episodes of Music and Medicine on Monday can be accessed by visiting the Iowa protocols through the QR code displayed or our website address, or merely searching on the web for Iowa Protocols, Music and Medicine on Monday.